Okay, let's unpack this. As you're gearing up for your finals, we're doing a deep dive into, well, the essential insights for really holistic mental health care. And this isn't just about, memorizing facts. It's really about sharpening your critical thinking,
Exactly.
helping you see how everything connects in patient care so you can synthesize all that information and build a truly holistic assessment.
Yeah, think of it like pulling together all those foundational concepts you've been working with all along.
Right.
Our goal here, our mission, is to really equip you to confidently tackle those complex scenarios you'll face, to see the whole nuanced picture, not just isolated symptoms.
Every piece tells a story.
Every single piece, no matter how small.
That's the goal. So let's jump right in. First theme, substance use disorders, SUDs.
Okay.
When we talk SUDs, we're really looking at the whole journey, aren't we? From how someone first presents, which can be super varied, to the long-term impact. It's about spotting those cues, even the subtle ones.
And spotting those cues, that's where critical thinking is just crucial. So picture this. A client comes in, they're agitated, maybe a bit paranoid, pupils are dilated, heart's racing.
Yeah.
They might even look underweight. What immediately jumps out at you?
Stimulants.
Exactly. That whole cluster strongly points towards stimulant intoxication. And the insight isn't just knowing the symptoms, it's recognizing this cluster means the body is pushed to its absolute limit.
Which has immediate safety implications.
Huge safety implications.
And how dramatically do those cues shift if we're talking about opioid use instead? Because the picture changes entirely, right?
It's like night and day. With opioid intoxication, you'd see pretty much the opposite.
Like drowsiness.
Yeah, drowsiness, those classic constricted pinpoint pupils. Speech might be slurred, breathing slow, heart rate down.
Okay.
And for those who inject, you might see track marks. But then flip that script for opioid withdrawal.
Right, the withdrawal phase.
That's where the body goes into overdrive the other way. Nausea, vomiting, sweating, yawning, muscle aches, tearing, runny nose.
It's awful.
Oh, it is. Dilated pupils this time, goosebumps, diarrhea. They feel absolutely terrible. But here's the key insight for your critical thinking.
What's that?
While it's miserable, seizures are not typical for uncomplicated opioid withdrawal.
Okay, that's a huge difference from alcohol or benzo withdrawal.
A critical difference. With alcohol or benzos, seizures are a very real, very dangerous risk during withdrawal. Not usually the case with opioids alone.
That distinction alone could really guide your immediate priorities, couldn't it?
Absolutely.
So, thinking long-term now, what about the physical signs of chronic alcohol abuse? What should we be looking for?
For chronic alcohol abuse, you're looking at really pervasive long-term issues.
Oh.
We're talking things like severe anemia. Their hemoglobin might be critically low, maybe around 6 GMDL. You'd see impaired coordination, that's ataxia, and diminished deep tendon reflexes. They might also have leukopenia, a really low white blood cell count, maybe 1,000 millicl.
Making them prone to infections.
Highly susceptible. The insight here is that chronic abuse doesn't just hit the brain. It systematically degrades the entire body. It creates this cascade of vulnerabilities,
Yeah, that makes sense. And for stimulant users, what happens when that intense high eventually crashes? What's the withdrawal like?
The stimulant withdrawal crash phase is, well, it's profound. After being in total overdrive, their system is just completely drained.
Exhausted.
Totally. Extreme fatigue, lethargy, often severe depression, sleeping excessively, increased appetite, and noticeable psychomotor changes. It's a complete collapse.
And the depression can be serious.
Very serious. Needs careful monitoring for safety.
Okay, so knowing these specific physical cues is vital. Let's zoom out a bit. What's the broader context, like with adolescent substance use today?
Right. Good question. When it comes to adolescent substance abuse, even though some trends for certain drugs might be declining, alcohol consistently remains the most frequently abused substance.
It's still number one.
Still number one. Holds true across various national surveys. That's a critical piece of info if you're working with younger people.
And understanding the why behind SUD development seems crucial for that holistic assessment, not just the what really predisposes someone versus factors that are just sort of associated.
This is where you really need to sift through the information, find the direct links.
Okay.
So direct predisposing factors for SUD development. Definitely powerful environmental influences, peer pressure, easy access, stress, trauma. Those are huge.
Makes sense.
Co-occurring mental health disorders,
Yeah.
depression, anxiety, bipolar, those are significant direct factors too. Genetics definitely play a role.
And early use.
Yeah, early experimentation with any sixthents, plus novelty-seeking personality traits, directly increase risk. Now, on the flip side,
Things that are correlated but not causative.
exactly, things like, say, academic underachievement, someone's spirituality, or their general educational background while they're part of the person's story, they are not considered direct predisposing risk factors for developing an SUD itself.
So distinguishing correlation from causation is key.
Absolutely critical.
So when a patient is in front of you, what are those undeniable red flags? The behaviors that just scream unsafe opioid use or addiction.
Yeah, those behaviors indicating unsafe opioid use or addiction are vital to recognize. We're talking about things like doctor shopping,
Visiting multiple doctors for scripts.
Right. Or taking more medication than prescribed, getting substances from non-healthcare sources. Maybe the client surprisingly downplays the risks of prescription opioids.
Or doesn't appreciate the overdose risk.
Exactly. Doesn't grasp the real danger. These aren't just isolated actions. They form a pattern that needs immediate attention.
Right.
And here's where your critical thinking connects the dots. You see these behaviors, you immediately think about interventions, like having naloxone ready for overdose reversal.
And also thinking about colleagues.
Yes. Recognizing impairment cues in colleagues is just as important for patient safety.
That's a really vital point. Patient safety above all. So shifting to recovery. When we talk relapse prevention, the recovery model emphasizes building strengths, right? Not just fixing deficits.
Precisely. The recovery model is all about empowerment. Critical relapse prevention strategies, things like sticking to prescribed meds, rigorously identifying and avoiding personal triggers.
Developing coping skills.
Developing robust, healthy coping mechanisms, absolutely. And building a strong, sober support network. That's key.
And what do we not want to do?
What we absolutely don't want to encourage is social isolation. That can completely undermine recovery. It's about connection, not withdrawing further.
Got it. Connection is key. All right, let's shift gears. Next big theme. Cognitive challenges and the aging process. So important as our population ages.
Hugely important.
It's about understanding those, sometimes subtle, but really profound changes in the brain.
And this is a core area where your assessment skills are just paramount, especially differentiating between delirium and dementia.
Okay, delirium versus dementia. What's the key difference?
The key insight with delirium is its acute onset. We're talking hours to days.
Super fast.
Yeah. Consciousness often fluctuates, cognition is altered, and crucially, it's often reversible.
Reversible, okay.
Why?
What kind of things cause it?
Think common culprits, polypharmacy, maybe decreased social interaction, or even something as seemingly simple as a UTI, a urinary tract infection, or substance intoxication.
So if an older patient suddenly gets confused, like over a few days, your alarm bells should be screaming delirium, not necessarily dementia.
Exactly. If confusion pops up rapidly, say over a week, you should immediately question a standard Alzheimer's diagnosis.
Right.
That sudden onset is your signal to actively hunt for other underlying, often treatable, causes delirium, infection, medication side effects.
Where's dementia?
Dementia, particularly Alzheimer's, has that gradual onset. It unfolds over months, even years. That's the fundamental difference in how they present.
That's a really powerful distinction for clinical judgment. Okay, so when we're managing a patient who's in the advanced stages of dementia, where do our priorities lie then?
For advanced dementia, the priority shifts. It's not about curing the disease anymore. It's about promoting comfort and ensuring safety.
Making their world make sense.
Exactly. Creating a world that makes sense to them rather than forcing them into ours. Think environmental modifications, good lighting, safety locks, consistent, predictable routines to prevent falls and injuries.
Structure is key.
Structured environments, clear pathways essential for minimizing agitation and confusion. And it's also fascinating, the overlap between symptoms of depression and dementia.
Oh, yeah. Like what?
Things like altered task performance, memory problems, difficulty concentrating, apathy, they can look similar. So careful assessment of the root cause is absolutely crucial.
Good point. And just generally, how do we best establish rapport with older adults, and what should we remember about the aging process itself?
To effectively establish rapport with older adults, it really boils down to respect and clear communication.
Simple but important.
Use proper titles, maintain appropriate eye contact, speak clearly, not too fast, give them ample time to respond, show genuine interest.
Patience.
Patience, yes. And understand that the aging process itself involves gradual physiological changes, It's highly individual, and it's not the same as disease.
Functional decline isn't inevitable.
Not inevitable for everyone, no. But sensory changes, diminishing vision, hearing, taste, those are pretty common.
Okay. And a quick note on safety with restraints and medications.
Right. If physical restraints are absolutely unavoidably necessary, then continuous face-to-face, one-to-one observation by trained staff is paramount. No exceptions.
Constant watch.
Constant. And for older adults on narcotic analgesics, be hyper-aware of the increased risks. Respiratory depression falls because of sedation and constipation. Major risks.
Got it. Okay, let's transition now. Mental health conditions affecting perception and mood. Psychosis and mood disorders.
Yeah.
This is where reality can get really distorted for people.
Yeah, definitely. When we talk psychotic disorders, let's focus on schizophrenia. It's vital to understand its phases.
Phases. Okay.
You have the active phase. That's where you see prominent positive symptoms, things added to reality, like hallucinations, delusions, disorganized speech, sometimes word salad, where words are just jumbled.
Okay, positive symptoms are additions.
Right. But then there's the residual phase. Here, negative symptoms are more prominent. These are things taken away, like anhedonia, the inability to feel pleasure, or avolition, lack of motivation, and what we call flat affect a big reduction in emotional expression.
So if a patient is having hallucinations or delusions, what are the nursing priorities? Safety first, I assume.
Always. For hallucinations or delusions, safety is absolutely number one, especially if they're command hallucinations telling them to harm themselves or others. So what do we do? Effective interventions include engaging the client in reality-based activities, using therapeutic communication that validates their feelings, really important, without confirming the delusion itself.
Validate the feeling, not the content.
Exactly. And distraction can be helpful too. So if a client thinks they're a famous celebrity, you validate their feeling of importance. I understand you feel very important. But gently redirect them to the present reality. Maybe engage them in a simple, concrete task.
So enter their world emotionally, but ground them in reality.
That's a great way to put it.
And the medications for psychosis, the antipsychotics, what's the really critical info about side effects? Because they can be pretty rough.
Oh, absolutely. Antipsychotics mainly work by blocking dopamine receptors. The key insight regarding side effects often revolves around extrapyramidal symptoms, EPS.
EPS?
Yeah. These can make patients feel incredibly uncomfortable. They often say they feel like a zombie because of things like bradykinesia, slowed movement, and muscle rigidity.
What are the specific EPS we need to recognize?
Okay, so there's acute dystonia. That's a sudden, severe muscle spasm. It can be really frightening for the patient.
Treatable.
Yes, usually quickly treatable with anticholinergics. Then there's akathisia, that intense inner restlessness, feeling like they constantly have to move.
Awful feeling.
Terrible. And drug-induced Parkinsonism, which mimics Parkinson's symptoms, tremors, shuffling gait. And the big long-term concern is tardive dyskinesia.
TD.
TD. Involuntary, repetitive movements can become irreversible with long-term use. Really problematic.
And there's one medication, clozapine, with a really specific critical monitoring need, right?
Yes, clozapine. The absolute critical thing is monitoring the complete blood count, the CBC, for a granulocytosis. A dangerous, potentially life-threatening drop in white blood cells. Monitoring is non-negotiable.
Got it. And briefly, first-gen versus second-gen antipsychotics.
Right. First-generation drugs are often great for those positive symptoms, but might not touch the negative ones much. Second-generation drugs, like paliperidone, for example, are generally better at hitting both positive and negative symptoms.
Which is huge for quality of life.
Exactly. And always be alert for neurological complications needing immediate assessment, like neuroleptic malignant syndrome, high fever, severe muscle rigidity. That's a true emergency.
Okay, emergency status.
Yeah.
Let's shift now to mood disorders, depression and bipolar. How do we assess for depression, especially when it might not just look like sadness?
Good question. When assessing for depression, sure, we look for persistent sadness, anhedonia, that loss of interest in things they used to enjoy, decreased concentration, maybe reduced socialization, lasting at least 2 weeks.
Standard criteria.
Right. But here's a critical insight for your holistic assessment. Depression looks different in kids.
How so?
Children often express hopelessness and despair not by saying I'm sad, but through irritability, physical complaints like headaches or stomach aches, behavioral problems, withdrawing, or a drop in school performance.
So you need a keen eye for those behavioral shifts.
Absolutely vital.
And the single most critical question we always have to ask anyone who seems depressed.
This brings us to maybe the most important question in mental health assessment. The priority assessment question for any depressed individual is always about suicidal or homicidal ideation. Are they thinking of hurting themselves or others?
Have to ask.
You have to ask. And here's a startling, counterintuitive insight. A sudden mood improvement in someone severely depressed can actually be a major warning sign.
Really? Why?
Because they might now have the energy and the resolve, finally, to act on suicidal thoughts they've had.
Wow. So improvement isn't always good news.
Not always. So directly asking, are you thinking about hurting yourself, is the most effective and necessary approach if someone expresses despair, like saying they're at the end of their rope.
Got it. Direct is best. And when someone's grieving, what should we be validating?
When managing grief versus depression, it's so important to validate those seemingly conflicting emotions like anger and guilt.
They feel confusing.
They do, but they aren't signs of pathology in grief. They are normal, even if uncomfortable, parts of the grief response. The insight is that grief is messy, it's not linear, and all feelings are valid.
Good reminder. Okay, antidepressants like SSRIs, SNRIs. What are the absolute must-knows for patient education?
For antidepressants like SSRIs and SNRIs, patient education is key. Number 1, emphasize it takes time, usually 2, 3, 4 weeks, to start seeing improvement.
Not instant.
Definitely not. And number 2, stopping abruptly is dangerous, can cause withdrawal symptoms. Tapering is usually needed.
Side effects.
Discuss common ones like weight gain, which can happen with paroxetine, for instance.
Yeah.
And here's a critical diagnostic insight.
Okay.
If a client starts an antidepressant and suddenly develops pressured speech, flight of ideas, really high energy.
This sounds like mania.
Exactly. That strongly suggests antidepressant-induced mania. It likely means there was an underlying bipolar disorder that the antidepressant unmasked.
So what's the action?
Usually, you discontinue the antidepressant, reassess the diagnosis likely towards bipolar, and initiate mood stabilizer therapy.
Crucial connection to make. Okay, now, bipolar disorder, specifically acute mania. What are the telltale symptoms we need to spot?
Symptoms of mania are often quite dramatic. Emotional lability, rapid mood swings, aggression, agitation, that pressured, hyperproductive speech where they can't stop talking.
High energy.
Incredible energy. Intrusiveness, loud speech, pacing, sometimes clang associations, choosing words for sound, not meaning, like rhyming nonsensically.
Got it. And lithium therapy, key mood stabilizer. What's crucial for patients to know?
For lithium, the absolute key patient education points are maintaining consistent hydration and consistent salt intake.
Why salt?
Because the body can confuse lithium and sodium. If sodium levels get too low, say from dehydration or cutting out salt, the kidneys hold on to lithium instead, and levels can rise dangerously, risking toxicity.
Okay, so toxicity is the risk. What does that look like?
Symptoms of lithium toxicity are serious. Persistent nausea, vomiting, diarrhea, blurry vision, ataxia like being drunk, and potentially even seizures requires immediate ER evaluation.
That balance is critical.
Very delicate balance.
So, nursing interventions for acute mania. What are top priorities?
For acute mania, priority 1 is reducing environmental stimuli. Move them to a quieter area. Structure their activities. Set clear, consistent limits.
Promote sleep. It gets disrupted.
Severely disrupted. So establish consistent sleep hygiene routines, create a calming environment, maybe a light carb snack before bed can help, and for therapeutic communication when someone's manic.
Yeah, how do you talk to someone with that much energy?
The goal is to gently focus that energy positively. Ensure safety, help them make concrete plans, maybe gently guide them to slow down if their speech is too fast. If a client says they stopped meds because they like the extra energy, it does. The best response isn't a lecture. It's exploring their perspective. Tell me more about what you like about feeling this way, or what's it like for you when you stop the medication? Understand or why.
Explore. Don't just confront.
Yeah.
Okay, let's move to our next area. How anxiety manifests and how we support people through crisis and trauma. Anxiety looks so different person to person.
It really does. When considering anxiety disorders, symptoms that should trigger evaluation include excessive worry or fear that's way out of proportion to the situation.
Physical symptoms, too.
Oh, yeah. Physical symptoms like headaches, muscle tension, difficulty concentrating, restlessness. These are different from symptoms you typically see in depression or mania.
And understanding the levels of anxiety is important for intervening, right?
Absolutely critical insight for assessment. Knowing the levels of anxiety. Mild anxiety actually increases awareness. Moderate anxiety starts to narrow the perceptual field, makes concentrating hard. severe anxiety. That leads to significant functional impairment, scattered thoughts, inability to concentrate at all.
Your intervention depends on that level.
Entirely.
Beyond meds, what are some effective non-pharmacological things people can do?
For sleep, like we mentioned for mania, consistent sleep hygiene, maybe that light carb snack before bed. For general stress reduction at home, techniques like concentration, just focusing on a single thought or your breath can be surprisingly effective.
Simple but powerful.
Yeah, and after a crisis, journaling is a fantastic way for clients to express and process feelings. If someone is in a full-blown panic attack,
What's the very first thing you do?
the immediate priority action isn't asking complex questions or trying to rationalize with them. It's simply speaking in a calm, controlled voice. Help ground them.
Commons can teach us.
Exactly. During panic, the primitive brain takes over. Your calm can help regulate them.
And back to meds for anxiety side effects like with paroxetine.
Yeah, with medications like paroxetine, like we said, weight gain is a common side effect to discuss. For social anxiety, SSRIs like sertraline are often first line because they treat the underlying neurochemistry.
And beta blockers.
Right, beta blockers like propranolol can be really useful for managing those immediate physical symptoms, the tremors, the racing heart that social situations can trigger. Doesn't treat the core anxiety, but helps manage the physical response.
Got it. Okay, moving to the very sensitive but crucial topic of trauma and abuse. What are the core principles of trauma-informed care we need to embody?
When providing trauma-informed care, especially with clients who might have a history of trauma, your whole approach matters. Remain calm. Maintain a safe physical distance. Avoid sudden movements.
Respect autonomy.
Acknowledge their autonomy, absolutely. Explain your actions before you do them. Offer choices whenever possible. This approach minimizes re-traumatization and starts building trust.
And with domestic violence, what are the key insights?
The critical insights for domestic violence: 1, it affects all populations, all socioeconomic statuses. 2, it's almost always cyclical, that pattern of tension building, explosion, then the honeymoon phase.
And leaving is hard.
Incredibly hard. Crucially, it often takes survivors multiple attempts to leave abusive situations. Fear, manipulation, economic dependence. It's complex. Substance abuse often co-occurs, and witnessing violence profoundly affects children.
So if a client comes in with injuries from domestic abuse, what's our absolute first step?
The very first priority is purely medical. Check their injuries, assess severity, address immediate medical needs, stabilize them physically.
Then safety planning.
Then, before they leave the ED, ensuring a workable safety plan is reviewed is paramount. And providing resources to a safe house or shelter, that's often the most important referral for immediate, ongoing safety.
Makes sense. How do we recognize child abuse or neglect? Key indicators.
Okay, physical neglect might show up as poor hygiene, clothing totally inappropriate for the weather, constant hunger, or untreated medical conditions that are clearly being ignored.
And physical abuse.
Physical abuse often involves unexplained injuries, injuries that just don't match the story the caregiver gives, or the child showing obvious fear of their caregivers. For sexual assault survivors,
Priority intervention.
priority intervention is creating a safe, supportive, completely non-judgmental environment. Behaviors like crying, pacing, even cursing the attacker, these can be part of an expressed response pattern. It's a normal reaction to trauma.
And long term.
The best sign of successful reorganization after assault counseling is the absence of ongoing PTSD symptoms. And quick note, if you're responding to trauma victims in a chaotic scene, use short, simple, concrete directions to guide them to safety. Keep it very basic.
And a realistic goal for someone with PTSD by discharge.
A realistic goal isn't that symptoms vanish, but that they will independently practice coping strategies for dealing with their triggers. Empowerment through skills.
Okay, last segment. Let's touch on the complexities of personality disorders and then zoom out to professional practice in mental health nursing.
All right. With personality disorders, a guiding principle. For clients with borderline personality disorder, safety is always the top priority goal because of the high self-harm risk.
And dependent personality disorder.
For dependent personality disorder, the priority goal goes beyond just managing symptoms. It's actively fostering independence and autonomous decision-making, helping them build self-reliance.
Okay, let's talk cluster B personalities. They often present with some challenging behaviors.
They certainly can. The cluster B group is often characterized by dramatic, emotional, or erratic behaviors. Someone with histrionic PD excessive emotionality, intense need for attention, maybe dramatically flirtatious. Narcissistic PD, grandiosity, constant need for admiration, profound lack of empathy. You might genuinely hear them say something like, I'm more important than these losers.
By antisocial.
Antisocial PD. You might see behaviors like spitting, cursing, aggressively testing boundaries. The key nursing response: calm, firm limit setting, direct, honest communication. Avoid power struggles. Don't personalize their manipulation.
What are their core symptoms?
Fundamentally, egocentrism, an inability to form mutually satisfying relationships, and just a consistent disregard for obligations and rules.
And avoidant.
Clients with avoidant PD often react to compliments with disbelief or self-deprecation. It stems from an intense fear of criticism and deep feelings of inadequacy. The insight is to look past the behavior to the underlying fear.
See the fear behind the reaction. Got it. What about non-suicidal self-injury? It's often misunderstood.
Yeah, non-suicidal injury or self-harm is fundamentally a maladaptive coping mechanism. It's not usually a suicide attempt. You might see it with histrionic PD, maybe for attention, or with borderline PD, often as a response to perceived abandonment or overwhelming emotional pain.
So therapeutic response.
Always explore what the client was feeling right before the action. It's about understanding the function of the behavior for them, not just judging or trying to stop it immediately. Understand the why.
Understand the why. Okay, let's broaden this out. Nursing practice. How does the role of a community mental health nurse differ from an inpatient nurse?
A community mental health nurse generally needs much broader cross-training. Think case management, social work skills, crisis intervention. They have to navigate multiple systems. An inpatient nurse often works within a more specialized, contained team.
More hats to wear in the community.
Definitely. And for medication compliance, especially with those long-acting depot injections,
What's critical?
2 factors are absolutely critical for success. 1, establishing trust with the nurse administering the shot. And 2, ensuring the client has reliable access to transportation to get to the clinic.
The medication only works if they can get it.
Exactly. It's about the whole support system.
So, wrapping up, what are some general safety principles for us to keep front of mind?
Just always remember, nursing assessments are fundamentally about recognizing cues that something might be getting worse, and then acting decisively to prevent negative outcomes.
Proactive, not just reactive.
Yeah, exactly. For instance, impaired judgment from substance use, say marijuana, out in the community. That requires priority intervention because of potential safety risks to themselves or others. And when it comes to therapeutic communication in tough situations, general responses always help. Validate feelings. I hear you. Your feelings are valid. Offer support. I'm here to listen. For aggression, maybe something like, I see you're upset. Let's try to find a way to make things better.
And boundary.
Always. Clear, consistent boundaries are crucial, especially with clients who might have paranoid personality disorder. Consistency builds trust and can reduce their suspicion over time.
Okay, so bringing this all together as you prepare for finals, what does this all mean? We've covered a massive amount. SUDs, cognitive issues, psychosis, mood disorders, anxiety, trauma, personality disorders. True understanding in mental health really comes from connecting those symptoms to the underlying conditions, understanding the why behind our interventions, and always prioritizing patient safety through critical thinking and that holistic view.
And what's truly fascinating here, I think, is that every behavior, every single symptom is a piece of a much larger puzzle.
Yeah.
Your role as you move forward isn't just to see those pieces. It's to ask, what story do these pieces tell together? And how can I help this individual author their next chapter?
That's a great way to think about it.
So stay curious. Keep seeking that deeper understanding and apply these insights, this way of thinking, to every person you encounter. It'll be invaluable, not just for finals, but for your whole career.